So welcome everybody to this week's OCAD lecture. Today's lecture is from Dr. Kam Shojania. Dr. Shojania is a clinical colleague and a friend of mine here in Vancouver. He's a clinical professor and head of the Division of Rheumatology, the Faculty of Medicine in University of British Columbia, and the head of rheumatology at St. Paul's Hospital and Vancouver General Hospital. He's also the medical director of the Mary Pack Arthritis Program and has received multiple awards, including UBC Faculty of Medicine Excellence in Teaching Awards, the UBC Master Teaching Award, the Howard Stein Award, and the Canadian Rheumatology Association Teacher Educator Award. So it's really a pleasure to have him here lecturing us and teaching us. He's also a significant researcher and has over 100 publications and 6 book chapters, so very prolific in that realm too. So I'm really looking forward to his talk. He's always gives excellent talks, and this one should be no different. So with that, Dr. Shojania, welcome to OCAD.
Thank you so much, Dara. It's really a pleasure and an honor to speak to your group. So this is going to be an update for radiologists. What's happened in rheumatology in 10 years? Because lots of us who've been out of practice, we stay in our little bubbles and we don't know about what's happening in other areas. So I'm going to give you an update, a sort of a whirlwind update of what's happening in rheumatology. This background here is the UBC, which is on Point Grey, which is on the western tip of Vancouver. Disclosures, I'm doing one investigator-initiated drug company study funded by BMS, but I'm stupid because I don't even get paid for this study. I do have shares in a company called Augurex, which developed a new test for rheumatoid arthritis, and that's based here in Vancouver. I'm going to talk about that. So I do have shares in that company, just so you know. I don't participate in pharma-sponsored talks or receive fees or anything. So today we're going to just talk a little bit about a whirlwind about rheumatoid, gout, ankh-spondylitis, psoriatic arthritis. I'll just briefly mention vasculitis. I would like to demonstrate where collaboration between rheumatology and radiology is so important, improve patient care and save money. And I'd like to provide some ideas for ongoing collaboration wherever you are.
I'd like to ask everybody to mute their mics. Thank you.
Rheumatology, just for you, reminder, it's a 2-year subspecialty after internal medicine, so it's a medical subspecialty. In UBC, we have 4 spaces per year of 8 residents. Last year, we had 3 spaces. We had 28 applications for our 3 spots. I think we're the best program in Canada, and there's our website there. Here's Vancouver, and if you could see my pointer here, yeah. Dara should be sitting right up, actually right there. That's where Dara is. That's West Vancouver here. Around the corner is Whistler. North Vancouver, downtown, that's Stanley Park, that green thing there. UBC, if you drive down here off to the point that way is UBC. And VGH is just a few blocks up here. Between St. Paul's and VGH is about a 5-minute drive. You could run there holding your breath, I think. This is VGH.
Of course, I'm a radiologist, Kam, so I don't get a window to see that view.
This is VGH. My daughter, Luck Louie, who's on this, and my daughter go to school together. They're teenagers. My daughter, who comes to work with me a lot, so does my son. But my daughter says VGH is like Grey's Anatomy, and St. Paul's is like ER. And I'm like, yes, that's exactly what they're like, both of them. Anyway, this is VGH. It's huge. It's like over 1,000 beds. This is UBC on the point. What do we do in rheumatology? Well, in UBC, there's 80 rheumatologists. There are 100 rheumatic diseases, and varying from musculoskeletal to autoimmune to vasculitis. Our average age of our patients is 42. We have a joke in medicine. What's the difference between cardiology and geriatrics? And the answer is, in cardiology, the patients are just a little bit older. But anyway, in rheumatology, average age is 42, frequently diagnostic dilemmas, as you guys know. We have minimal procedures. We do capillaroscopy, we do joint aspirations, there's some point of care ultrasound. But in 10 years, there's been such a huge impact on disease diagnoses, treatment, and cure. And our patients in rheumatology go from multi-organ failure in the ICU back to work. So it's an amazing subspecialty. We do research here at ARC, Arthritis Research Canada, which is a not-for-profit UBC affiliated organization. And there's lots of fantastic stuff happening at ARC. How has office practice changed in rheumatology? Well, here, 100% of us are on electronic medical records. We use AI to help with diagnostic dilemmas. We use a program called QXMD, which was made by a nephrologist here in Vancouver. And I'm sure all of you, if you don't use it, you should use it. It revolutionized the way we, Dart used QXMD, I'm sure, right?
Yeah, we do, yeah.
Yes. So it's really changed the way we read papers. The other thing that's revolutionized our practice is something called Care Connect here, which we can see imaging from every hospital in our province of 4.5 million people, and labs from private and public labs all come together. We also see prescriptions from everyone in the province. So it's really improved our care and saved money. The other thing that's changed our office practice is meeting with BGH and St. Paul's radiologists weekly. This has improved our care and is really one of the best things we've done in the past 10 years. Exercise is medicine. The other thing that's changed our practice is we know that exercise improves not only osteoarthritis, but inflammatory arthritis. And we're focusing on disease complications of our conditions, including cancer, cardiovascular disease, and infection. So if I get, that's a bit overview of what's happened in the past 10 years. So read here up in the right-hand corner. An example of AI is Isabel, and it helps us with these rare diagnoses. That's our secret now. Secret's out. We use AI to get these very, very rare things like VEXAS syndrome, Care Connect, and EMRs. And at the rate, and what we meet with the radiologists once a week at both St. Paul's and VGH. We review cases where there's diagnostic uncertainty. We review outside films. Interesting cases are brought forward for review or teaching. There's a few radiologists, few rheumatologists, and our trainees, and we mostly just argue about stuff. We point out where interventional radiology may be useful, biopsy, guided injections, procedures. We talk about treatment plans, teaching and learning, and we discuss research ideas and other collaborations. So I think it's priceless. And if wherever you are, talk to people, radiologists here, make sure you're meeting with the rheumatologists. Zaki is a little puppy. He is an American Eskimo, very curious, serious little fella. Rheumatoid arthritis. So what's up with rheumatoid arthritis? We can now put rheumatoid arthritis into complete remission. And it's not those fancy biologics, though they are amazing. We use 3 old medicines, 3 old, but the caveat here, and this is where radiology, it's important for you to know, we need to catch it early within 6 months of symptoms. So symptom onset takes a month to see their GP to talk about it, refer to rheumatology, maybe take a couple months. We're already in there for a few months, so we need to catch it as soon as possible. If we catch it within 6 months, we can put it into remission, and sometimes we call drug-free remission. Later on, with established RA, we can also put it into remission. It's harder and it needs more expensive therapy. So radiology, we need your help by making diagnosis early. MRI, ultrasound, it's key. Because we don't want to wait till there's CIPs here, MCPs. We don't want to wait till this happens. We don't want to wait till this happens here with the in the patient. We want to catch it even earlier than that. And there are a whole bunch of studies. Some of these are from Canada that delay in rheumatology care leads to long-term harm. Window of opportunity. That's what we like to call it in early rheumatoid arthritis. We can alter the disease progress. And the secret is that it almost doesn't matter what you do 5 years. What you do at the beginning will change the long-term outcome from a disabling disease that causes early mortality and morbidity to a more of a minor problem later on. In diagnosing rheumatoid arthritis, 40% of the score relies on blood tests. This is the criteria for we developed this is the thing that I helped with, this thing, biomarker called 1433 ATA, which is a new test. So we have rheumatoid factor, we have anti-CCP, and now we have this joint stat, we call it, or 14, which is an intracellular chaperone that is mostly intracellular. In rheumatoid arthritis, it becomes extracellular where we can measure it. And we've showed that rheumatoid arthritis, very established rheumatoid arthritis is very high. Early rheumatoid arthritis controls healthy other arthritis, like psoriatic arthritis, osteoarthritis. Because we really want to avoid this. When I see, I'm very sad when I see this in the office. That means it's a failure of the process, especially if it's happened within the past 10 years. Lateral deviations, swelling, rheumatoid nodules, synovitis that almost reminds you of lymphoma with all the aggregates, and of course the arthritis. Untreated rheumatoid arthritis has a mortality comparable to 3-vessel coronary artery disease, stage 4 Hodgkin. And without treatment, 50% of RA have irreversible joint damage.
I'm going to interrupt. Kam, do you have a different type of mic? Your sound is going in and out, or?
I do not, but how about this? Is that if I just move it?
That's better.
Okay. What's new in pathogenesis of rheumatoid arthritis? I think we definitely know smoking increases the risk of rheumatoid arthritis by several fold, and smokers do not respond as well to disease-modifying therapy. Obesity increases risk of developing rheumatoid arthritis, also makes it harder to treat, probably because adipose tissue increases inflammation. There's probably an effect in the microbiome, specifically periodontal disease. So gingivitis increases rheumatoid arthritis. And we know that there are certain genetic factors in North America. Our First Nations, Aboriginal Americans have an increased risk. So, and family history is important. So if you have a First Nations, that's what we call them in Canada, First Nations patient with a family history of rheumatoid arthritis who is a smoker with gingivitis, and they might have HLA-DR4, they almost for sure will get rheumatoid arthritis. The question is, should we treat that person before they develop disease? Anyway, that's an ongoing study right now. So you hear a lot about the biologics. Anti-TNF they were the first commonly used biologic in rheumatoid arthritis. And basically, they just mop up cell surface or soluble TNF and reduce inflammation and prevent damage. They were a game changer in about the 2000. But what they also did show us is that better use of our old drugs actually was as good as biologic therapy. There are 3 ways.
Kam, I accidentally muted you. Hold on, let me unmute you. Oh, sorry. Hold on.
How's that?
Yes, much better.
Okay. All right. I was saying there are 3 ways to inhibit TNF. I'm not going to go into the detail there. Rituximab is anti-B cell therapy that also is a very helpful treatment in rheumatoid arthritis. And abatacept is another one. But here's an interesting one, tocilizumab, which you now hear in the treatment of COVID. We wrote a paper last year using tocilizumab for cytokine storm syndrome in COVID, and it is now used everywhere severe COVID now. Triple therapy, this is what I was talking about before. It's as good as biologic therapy for rheumatoid arthritis, and that's simply methotrexate, hydroxychloroquine, plus sulfasalazine. So if you're in an area where it's hard to access biologics or the patient cannot afford it and there's no universal health care, triple therapy is as good at 1/20th the cost. Radiology input is important in rheumatoid arthritis, as I said previously. The early diagnosis is the key. We might ask for plain x-rays in established disease looking for erosions. It's a little too late at that point. Ultrasound of the hands for early lesions versus MRI of the hand, especially to make a diagnosis in our seronegative patients, RF negative CCP. Should we do office ultrasound for hand lesions in different countries? It's very frequently done. In Vancouver, we have a couple of people that do it. And they don't pretend to do anything else but look for synovitis in their ultrasound. Zaki is now getting to become a teenager. He's getting a bit longer legs and still that serious little look. This morning he woke up with, we have bed head, he has bed face. So he had bed face this morning. Gout. So this is an old picture of I think you might have seen this before, of a fellow with gout. And he has a little devil banging on, poking at his toe, and these doctors and people trying to help him. We showed that hospitalizations for rheumatoid from 1993 to 2011 were significantly dropping. Hospitalizations for gout started to increase as well. And really around 2005 was the period where gout hospitalizations exceeded rheumatoid arthritis hospitalizations. I find that very interesting. And you may wonder why. We'll talk about that a little bit. Gout, basically, you'll get referrals for query gout. If the patient is a premenopausal female, then the likelihood of gout is vanishingly low. In fact, I would say 0 if their kidney function is normal. If they have renal failure, all bets are off. But both men and women, gout increases with age. It starts to ramp up for women postmenopausally, as you can see. And for men, it continues to climb with age. And here's a slide with men. This is the data we showed in BC. Again, men and women increasing gout over the years. Wonder why that is. What's happened between 2000 and 2012, and it continues to grow. I have some blame to throw out there. I blame a little bit our internal medicine colleagues and their blood pressure medications. They use a lot of thiazides, and as you remember from med school, thiazides increase serum uric acid. I think our diet, specifically, we showed, I'm going to come to diet in a moment. So basically with gout, as serum uric acid goes up, we make crystals, we get gout attacks, and we get tophi. All right, it's very, very simple. If we suppress serum uric acid, crystals will disappear, and eventually the patient is cured. It's really one of the rheumatic diseases we can completely cure. Why is it still out there? I blame a failure in the system somewhere. So if you're whenever you see gout, specifically tophaceous gout, it's a failure of the system wherever you are. Gout criteria have changed. The classification of changed. Of course, in the top right, if you see crystals, that's the diagnosis is made. If you don't have crystal diagnosis, then you can use onset, like recurrent episodes, podagra in the first MTP joint, can't bear to touch or put pressure on the joint. But also serum uric acid is helpful. But here's what's new. Imaging evidence of urate deposition is now part of the criteria, either ultrasound evidence or dual energy CT evidence of gout. And a study we did in 2008 and 2009 showed, we were always very excited about these back in the 2000s. about uric acid deposition. These are, of course, very severe patients with large tophi. We were struck by the presence of tophi in the periarticular regions as well, more than we thought, that's for sure. And then we were excited about the 3D representation. But here's something interesting, that patients who we think have gout, we aspirated the joints and no crystals were seen. If you do a dual energy CT scan on these folks, about half of them will be dual energy positive. And on further ultrasound guided aspiration will show positivity. So the previous gold standard of doing a joint aspiration and demonstrating crystals probably isn't the gold standard anymore. And I think we need to change our approach to gout. Of course, I'm happy to stick a needle in a joint when patients have podagra, as some of the radiologists on this call will have had. It's a very painful joint, right? Let's say 9 out of 10. So when I stick a needle in it, it's briefly 10 out of 10. So, it's not that bad. Here's gout and diet. This is one of my colleagues, Hyun Choi in Boston. And he really turned upside down the idea of diet and gout. First of all, what's good for gout? Daily exercise and weight control. Whole grain foods, plant oils, olive oil. Cherries actually reduce gout, and that's been shown. They're uricose-uric. So you radiologists on the line with gout, and you know who you are, you could have a little a handful of cherries when they're in season, or cherry juice also works once a day. Nuts and legumes are safe, but what increases gout are meat proteins and beer. The other thing that Dr. Choi showed was that high fructose corn syrup, which is primarily in store-bought sweets and pop or soda, whatever you call it in your country, that is very bad for gout. So if you want to treat your gout, you can drink wine. Wine is okay, but beer is bad. Reduce your meat proteins, but you don't have to make them disappear. And basically stop drinking Pepsi, Coke, 7-Up, whatever you guys have. That's the magic treatment for diet treatment for gout, is simply that. How can radiology help us with gout? Well, I think you can help us either whatever's easier for you, but ultrasound or dual energy CT scan. We use it in the diagnostic criteria now. I think we've learned that urate deposition doesn't always mean the diagnosis is gout. You could have gout and other conditions at the same time. You could have gout and septic arthritis. So just because you get a call from EMERGE to scan someone and you see there's uric acid present, that doesn't mean the patient does not have septic arthritis, right? Gout can be cured. And like I said before, tophaceous gout is a failure of the system somewhere. I like to tell my patients that when they come in with tophaceous gout, I said, well, if you keep having this gout, it's either your fault or my fault. So, and that's, I think, true. Gout pearls for radiology. Yes, gout can often coexist with osteoarthritis and psoriatic arthritis, and we often see that in our rounds. Gout rarely coexists with rheumatoid arthritis, but I've been seeing it more frequently, and maybe they still deposit uric acid, but maybe for some reason the synovial milieu is not conducive to gout attacks. And again, like I said, gout almost never occurs in premenopausal women with normal kidney function. This is where my parents live on Vancouver Island, and this is Arbutus Cove. And this is my dog hanging out where they live on the cove, and you can see it's getting a bit bigger. In the picture to the right here, that's the United States. That's San Juan Island. So from my parents' place, you could see the United States over there. And sometimes when I'm visiting, my phone starts roaming and they think I'm in the US. So I suddenly have like a $60 phone charge. Oh, okay. So spondylitis. Here's another area that we realize that, you know, when you guys are trying to figure out, based on radiology, whether the diagnosis is ankylosing spondylitis or psoriatic arthritis or reactive arthritis, you know what? It's probably as you guys have realized, a spectrum of the same condition. There's axial disease, there's peripheral disease, there's enthesitis, dactylitis, arthritis, there's inflammatory bowel disease. In fact, if you take a patient with Ank-Spon who has no bowel symptoms and scope them, they will have frequently subclinical inflammatory bowel disease. There may be a urogenital connection with chlamydia. There's the psoriasis, and then there's a uveitis. So I don't know if it's helpful. So don't, I think, stress about whether the findings are psoriatic arthritis versus spondylitis versus other. You can just describe what you see: sacroiliitis, bilateral, unilateral, syndesmophytes, enthesophytes, enthesitis. You can also help diagnose psoriatic arthritis if you're talking to the patient and you're doing an ultrasound, you can ask them if they have psoriasis, scaly red or pink rash. You can ask them if a first-degree relative has psoriasis, because it's very inherited. And that counts, having a first-degree relative with psoriasis.
Can I interrupt you there for one sec? There's just a technical issue. There's a little yellow box that's popping up on our screen. I'm not sure, do you see it, saying, please move this window away from the shared application? And it may be because, yeah, that's it. Now we don't see it. I wonder, is it because you have a window over top of your presentation window?
Okay, good. Okay, perfect. Thank you. Is that better?
Well, we don't see your screen. We don't see your shared screen anymore. We just see you.
Okay, just a minute then.
So share
screen like this. That work better?
Yeah, perfect. Thank you. Yeah, thanks.
All right. What features of psoriasis increase the risk of psoriatic arthritis? Well, when the psoriasis in these places: scalp, umbilicus, or gluteal cleft. If they're extensive psoriasis and there are nail changes, which this is a picture of dactylitis here, right? And this toe here, little chubby toe. I think this one has dactylitis as well. Dactylitis here. The toe should get smaller as they go down. This is the normal one. And then you've got 1, 2, possibly 3. And then here's a nice picture with nail pits. It's hard to get it. You can see them on in certain lights, but they are little divots in the nail. Remember, there are 5 forms of psoriatic arthritis. There's the most common one, which is the asymmetrical oligoarthritis. There's polyarthritis that looks very much like rheumatoid arthritis, perhaps more DIP involvement. There's this one where there's DIP only, but these people always have nail changes, which can help differentiate them from OA of the DIP joints. There's the dreaded arthritis mutilans, and then there's the axial type, which is very similar to ankylosing spondylitis. You can sometimes move from one of these to another. Often people are asymmetrical oligoarthritis before they become polyarthritis. They will start oligo before arthritis mutilans, but once they have settled into that phenotype, they primarily stay there. This is the DIP variant. So you'll see these X-ray images as quite marked damage at the DIP joints, and you think this must be like the worst osteoarthritis I've ever seen. But they will probably have some pencil and cup deformities. If you actually saw the pictures of their hands, the diagnosis was come to you because they have quite severe nail involvement here, and there's patches of psoriasis here as well. And then, you know, it's very sad when we have to see this progression of this. This is the DIP joint with pencil and cup deformities over time. Sadly, with ankylosing spondylitis, there's an average of 10 years between the symptom onset to the diagnosis. That really doesn't change very much. You guys, and in the old days, the diagnosis was made with sacroiliac joint X-ray changes, which is quite late in the progression. MRI changes are earlier. And symptom onset, the MRI and X-ray are often normal. So who knows what process starts the disease? Is it some thoughts of molecular mimicry with gut bacteria, leaky gut? in people with HLA-B27, but symptom starts. The first findings will probably be MRI bone marrow edema that I've learned from my radiology colleagues. X-rays are normal. And then later on, when symptoms are really present for a long time, there'll be some X-ray changes. And we used to grade, some of the older radiologists will remember that we would grade 1, 2, 3, 4 with SI joints. And, but you know, X-ray really just detects only chronic bony changes. They're part of the New York criteria, so we use them in our research studies. But there's a lot of radiation. The American Ankylosing Spondylitis Association, I can't remember the last S, recommends whole pelvis X-rays, hips and SI joint views, but maybe low-dose CT is probably better than X-ray, but not in our diagnostic criteria. And MRI detects changes much earlier, but may be difficult to access in certain places. And because I use these slides for rheumatologists, we put circles around them. You guys don't need the circles, but there are so many early changes in MRI that you guys know better than I do. When should we order an MRI for spondylitis? I think when the clinical picture doesn't fit or there are red flags for fracture or another process going on, ruling out infiltrative processes or discitis. Also, if you're not completely sure the diagnosis is ankylosing spondylitis, because I tell my colleagues that they're thinking, well, it's probably ankylosing spondylitis. I tell them just make the damn diagnosis because it will change the patient's life forever. And when the treatments are expensive at up to $20,000 Canadian dollars per year, it's higher in the US, it makes sense to nail down the diagnosis initially with MRI. The MRI costs $800, but the biologic is going to be $20,000 a year. You know what? Spring for the MRI. That's what I tell the docs because it really makes a big difference in long-term treatment. I think what did we learn in our radiology rounds is over-interpreting sacroiliitis on plain films may produce the wrong diagnosis. So interpreting normal ones or sometimes abnormal ones turn out to be normal. Maybe CT if you think it might help, if it's late stage. The other thing we learned in radiology rounds is report SI joints when looking at CT abdomen in people with inflammatory bowel disease. If MRI is difficult to obtain, get a CT. MRI, SI joints, and spine. When they're ordered by rheumatology, please obtain the appropriate sequences to look for bone marrow edema. I think, Dara has told us that we need specific sequences to look for bone marrow edema, and they're not often done when their MRI has been done for neuroradiology reasons for nerve impingement. And maybe you can expand on that at some point, Dara. Additional suggestions from the rheumatology colleagues. When I was giving this talk to radiologists previously, I emailed my colleagues and said, hey, what should I tell the radiologists? I'm going to chat with them. And they all said, thank you for all the collaboration. That's the first thing they said. The other thing they said, if they want to be nitpicky, they said, hey, tell them when they're interpreting chest x-rays, be consistent in reporting of spinal compression fractures. I wonder if that's a problem everywhere. Hand x-rays, someone said reporting erosive osteoarthritis may be technically correct, but often triggers a rheumatology consult. And it doesn't really matter for us if it's erosive osteoarthritis or regular osteoarthritis. We can't do a damn thing about it either way. So these are just some comments from my rheumatology colleagues. So this is Zaki full grown. He's a majestic looking creature. I just want to say about vasculitis. In 2012, we completely changed vasculitis nomenclature. We call it's large, medium, and small vessels. I know, and here and this will be in the slides that I'll send maybe to Hillary to post if you want, Hillary. There are, we call GPA, what we used to call Wegener's, and EGPA, what we used to call Churg-Strauss, small vessel vasculitis. IgA vasculitis used to be called Hanoch-Schönlein purpura. We have hypocomplementemic urticarial vasculitis. We have the large vessel vasculitides. And And here's a sort of list of them. I think I'm not going to go into anything with vasculitis except imaging is crucial in the diagnosis, staging, and monitoring of vasculitis. And really, we have no clue. We need your help in choosing the right modalities based on the patient situation. Angio, CT angio, MR angio, PET scan maybe. And treatment of vasculitis has really improved substantially with the newer biologics. We get a lot of help with our vasculitis clinic at VGH, Dr. Degan. But I think wherever you are, when the rheumatologist is asking about vasculitis, we need lots of help in these potentially very sick patients where we can turn them around quite nicely. So I'm going to stop. I just wanted to say rheumatology has rapidly advanced over the past 15 years. We have advanced costly treatments for our diseases, upwards of 20,000 Canadian per year. And it's important to make the diagnosis early and correctly now. Rheumatoid, spondylitis, psoriatic, gout. We realize now that collaboration with radiology is essential for our practice, and we very much appreciate the opportunity to work with our outstanding radiologists. Thank you very much, and I'm happy to answer questions or talk. And Dar, maybe you could expand on anything I said, particularly the MRI sequences.
Yeah, thanks, Kam. That was a great overview, I think, of where things are in the state of in the world of rheumatology at the moment. The MRI for SI joints is interesting, and for spondyloarthritis, you know, there's no one size fits all, I think, is the key. And so we will often get a request that says, you know, MRI C-spine, T-spine, L-spine, SI joints, and we're like, not sure do we need that. And so, you know, we have a spondylitis MRI you know, protocol that includes the SI joints, and then includes the lumbar spine. And I think that's useful in cases where there's a question around the diagnosis, not necessarily clarify an abnormal X-ray or maybe a CT that's a bit funky looking at the SI joints. There you can do just a dedicated SI joints. But when you're looking for the diagnosis, which could be subtle and may affect only the lumbar spine, it's important. And in those sequences, we actually extend the SAG stir up to include the lower costotransverse and costovertebral junctions of the lower 2 or 3 vertebrae, because we often see subtle changes there that can help clinch the diagnosis. And we do that in the coronal and sagittal planes, which I think is helpful. I'm sure other sites do similar variations of that. But we do try and avoid the whole pan scan of the spine, unless there's a very specific question about, you know, mid-thoracic or cervical spine pain in someone who's got asymptomatic elsewhere. So, I mean, happy to take comments or questions from others on the call, or general questions about anything rheumatology related. One thing that we've discussed often, and I think it strikes fear into most radiologists, but it's the concept of patients who present with a septic arthritis and whether or not to give steroids. And we've always been taught it's a major no-no to give steroids intra-articularly to someone who's got a septic joint. And I think that, for me, one of the things that I've learned from you is that maybe the confusion is that if you don't know that the joint is septic and you give steroids, you're going to mask an infection, and that could be catastrophic. If you know someone has a septic arthritis, actually giving intra-articular steroid might actually help them a lot symptomatically, and won't cause necessarily a progressive, you know, cartilage loss or worsening arthritis, but actually may help them. I think it's something that I certainly it was something that I hadn't practiced before, but with your support and in very select cases, we have done that with some success. So I think that was kind of another interesting sort of collaborative thing that I've learned from you over the years.
Actually, let me expand on that too. Yes, if you aspirate the joint and say there's Staph aureus in that knee, and we've got them on antibiotics, but we keep aspirating the knee and it's inflammatory, and what's killing that cartilage isn't the infection, but our own response to it. So there's some really good data to show that if you inject that knee with steroid, you're going to reduce that inflammatory response while you're treating the infection. So yes, that's exactly right. It's okay to I'll say it here, and I know Hillary's recording it. It's okay to inject an infected joint if you know it's infected, the patient's on treatment, and you know exactly what you're doing. Where the mistakes happen is someone comes in with knee pain and a swollen knee, and you inject it with steroids. You didn't know it was infected. They feel better, but then the infection comes back with a vengeance in a few days. Yes.
Right.
I have a question. That That was great. And I'm glad I'm going to just cut out that clip and play it for my referrers. That's fantastic. I continue to struggle almost every week reading SI joint MRI, and you know, you all emphasize the fluid sensitive sequences, and yet honestly, every time I'm confused, I save key images and I send them to Rob Lambert to help me out. And he always expounds brilliantly. I don't know if he's on here, but I'm not sure that I'm getting any less confused. I thought I learned something the last time, that it was important to look for the structural changes on T1 weighting, and that marrow edema is completely non-specific. And, you know, it's really frustrating to me, like you said, make the damn diagnosis, that it's taking 10 years because they're so strict with the criteria, because it's basically a life sentence and it's a very expensive endeavor. Yet it sounds to me like we really need these structural changes. So I'm really completely confused. Can you make the diagnosis on the marrow edema pattern, or do I need to see the erosions on T1?
I see we've got some very illustrious people on this call. So, but I feel that in our regular weekly rounds, Dara, we see marrow edema and we don't think it's specific, right? Like,
right.
what if
I think that's
a marathon? Like, there's a lot of active people here in Vancouver, and they're going to get marrow edema.
Yeah, and sometimes it's just it's something to flag and to note, you know, to note for follow-up. But unless you see either, you know, deep erosions on T1 or backfill or something that just suggests chronicity, but just things like fatty metaplasia.
Now they have to be deep erosions?
Well, from my understanding from Rob Lambert, is that to be a centimeter.
Oh, I better amend a report from the other day then.
Well,
so,
you should.
I was going to ask you the flip side of the question, because I just saw a case where I saw erosions on T1, but there was no marrow edema or active synovitis.
Maybe they were treated.
No, there was no established diagnosis. So what do you do with that?
Yeah. Oh, well, you know what's interesting? This is such a weird disease. We have people with terrible Angst-Bond symptoms when they're 20s, and it burns out. So we see them later and we do imaging for another reason. Someone says sacroiliitis refers to me, and they're like, oh yeah, when I was in my 20s, I had back stiffness, morning stiffness, night pain, but I don't have it now. I examine them, they look good. They're B27 positive. They had Angst-Bond and it's burnt out. And we see that all the time. So I wonder if
not remain symptomatic from.
Does not have to, but I guess they can have back pain too.
Right. Interesting. So,
yeah,
so they must be out there with the structural changes, and we don't know what to do with that.
We do. We see, and you know, when I see them, when I'm on call for rheumatology, I get called by cardiac surgery, which is a bad call, and it's valvular. They take out someone's valve. It's inflamed. They're like, hey, something's going on. Is it aortitis? I examine the patient, nothing. I image them. They've got sacroiliitis. I had this 70-something-year-old lady with sacroiliitis, no symptoms, but her family had Angst-Bond and she had aortic valve disease. So it's a very interesting disease or spectrum of conditions that have various phenotypes, and you will see imaging changes on them, but not all of the imaging changes need to be treated, I think.
I'd like to pick your brain just because you mentioned vasculitis. I know you didn't talk much about it, but I'm lucky enough to have something called chilblains.
Oh, yes.
And I understand it's in the family of vasculitis, but it's self-limited and it goes away. And it hurts like hell. And sometimes it even looks kind of like gout, although I shouldn't have gout. And there's nothing really to do to modify the course of it, as far as I know.
Yeah, I love it because it's such an old-fashioned diagnosis. You see it in Dickens, right?
It's actually supposed to be mostly in, you know, like your crowd, Dara. It's, I think the highest incidence is
central heating, yes.
Ireland and Scotland, and it obviously made a mistake when it got me.
And it's a vasculopathy, not vasculitis. So it's where immune complexes deposit in the coldest parts of the body, which is fingers and toes. and keeping core and extremities warm, making sure, you know, you don't have hepatitis C or something, you know, that can cause immune complexes, which is very unlikely. But
so it's not related to, you know, an unspecified arthropathy or anything like that.
We see it in lupus, but the vast majority of people out there with chilblains do not have lupus or autoimmune disease.
Interesting. Clinically, you can get a swollen digit that almost looks like a sausage digit, or it looks like gout. It's really nasty.
Yeah.
Yeah. Well, now that everybody knows my tales of woe, does anybody else have a question for Kam?
Yeah, hi, Kam. This is Don Resnick in San Diego, and I really appreciated your talk. I wanted to give a little perspective from a radiologist who's been around a long, long time. I started in bone radiology, and my first love was arthritis because I found it that the radiographs were so specific that I thought it was a very, very easy job to differentiate among various articular diseases. What I have found in recent years is the job is much more difficult because of the disease modifications that currently are done with the various therapies. So the diagnosis is far more difficult now than it used to be 30 years ago. One of the things that also has interested me through the years is the change in some of the basic concepts about these rheumatologic diseases. Let me give you an example. When I was taught in a residency, rheumatoid arthritis was a disease of the synovium, and osteoarthritis was a disease of cartilage. And in recent years, there's a lot of information about crosstalk between bone and cartilage and synovium, such that there may be more than one target tissue. I wonder if you could address this, explain crosstalk, and tell me what vocabulary is being used in that particular language.
Well, first of all, I missed most of the question because I'm just so excited that Don Resnick is talking to me. No, I'm just kidding. But it's a pleasure and a privilege to talk to you, Dr. Resnick. It's our fault for talking to med students and saying osteoarthritis. We still say osteoarthritis is a mechanical problem, and rheumatoid arthritis is a synovial problem. You're right. And we now realize that osteoarthritis is an inflammatory disease. You guys have started to tell us that based on imaging. And it's really, we are looking at new biologic therapies for osteoarthritis. We're looking at inhibition of inflammatory responses in osteoarthritis. We're looking at the connection between adiposity and osteoarthritis. Similarly, with adiposity and rheumatoid arthritis, it increases both. So you are absolutely right. We are right now in a flux because we know osteoarthritis is not simply a mechanical problem, but we really have some new treatments available. So stand by for osteoarthritis. And I suspect we're going to see 3 or 4 different types of osteoarthritis: the nodal finger osteoarthritis, the inherited kind, versus the large joint osteoarthritis, versus the dish type. Like, what's dish? You know, is it like an osteoarthritis plus, or is there a growth hormone issue? So I think we need to really have specific osteoarthritis specialists. One of our researchers, Dr. Yolanda Sabir, expands beautifully on osteoarthritis. So I think osteoarthritis is going to be very big in the next 10 years, if you were going to ask me what's going to happen. So yes, I agree. There are different diseases, rheumatoid and osteoarthritis, but osteoarthritis is not as simple as what we used to think.
Can I ask you one other question? And one of the diseases that you did not mention is calcium pyrophosphate disease. And I've had an interest in it for years and years. You know, much of the work that we've done here at UCSD has been imaging pathologic correlation. And we've had access to cadavers, most of which derive from older persons. What has impressed me through the years is when dealing with these cadavers derived from older persons, calcium pyrophosphate disease is almost always present, not just in cartilage, but in ligaments, tendons, synovium, even in soft tissues. So I ask you, is calcium pyrophosphate a disease, or is it simply something you get as you get older?
I agree. It's it's as you get older, bone calcium goes from where we want it, which is in the bone, to where we don't want it, which is in the tendons and the vessels, right? The blood vessels. And I think it's a process where it's part of the inflammatory healing process. So we have it in our tendons after inflammation and injury. We have it in our vessels after inflammation. So I think it's like a comorbidity. I don't think it's a natural process, though we mostly get it as we get older. And it is such a difficult thing to treat. We treat it, our radiologists do they can get rid of it in the shoulder tendons. We can surgically remove it, but we don't have a medication yet. We use colchicine, of course, for flares. We use NSAIDs, but we don't have a way to get rid of the calcium like we do for gout. What's our biggest problem with calcium is calcinosis with scleroderma. We have no treatment for it. It's terrible. And we just don't have treatment for the calcinosis or specifically for calcium pyrophosphate disease. But to answer your question, I think it's pathologic, but increases as we get older.
Yeah, thanks for the answers. And again, I really appreciate the talk. It was terrific.
Thank you, Dr. Resnick.
One more question, Kam, that I had, and maybe it's more for the participants than for you, but you mentioned we started when you were talking about gout, about the different imaging modalities, and we use dual energy CT for the diagnosis of uric acid deposition. There, in my eyes, there's a very big chasm between different vendors, CT vendors, in terms of who does it well and who doesn't do it well. I think the Siemens sites, certainly here locally, have a distinct advantage, and they do gout imaging really nicely with dual energy. We're a GE side, and I think GE does a terrible job, to be honest. Are there other people on the call who have had this experience, or are there other CT platforms out there that do a good job of dual energy in gout arthritis and picking up gout crystals in their cases?
No, Dara, that's our experience too. We had a GE system and it was horrific, and now we have different Siemens unit. Very easy to do the.
I can't hear you.
And Bob Lopez the same. Okay, thanks for that. Appreciate it. Yeah. Anyway, any other systems apart from Siemens that are good? Does any Philips or Toshiba or I guess they're Canon now? Anyone else is aware of a good system that does dual energy?
Hey, sorry, Dara.
Yeah,
this is a great talk, Cam. Really enjoyed it. This has a very quick question. We do a lot of ultrasound, some MRI, looking at rheumatoids. When they're still having issues, inflammatory markers are going down. We're looking for synovial hyperemia, usually with power Doppler. As you said, back when I first started teaching this, it was easy. Oh, a lot of synovial hyperemia. That's definitely RA. Now we don't know. I mean, obviously, if it's in a polyarticular or rheumatoid type distribution, we favor it being an inflammatory synovitis. But now with our new power Doppler sensitivity, I mean, we are seeing one little vessel, and could it be OA? Could it be related to the RA? Still has some inflammation. How do you guys deal with that clinically? Because we try to just not be very dogmatic on our impressions, but I always feel that's kind of wishy-washy.
I think it's okay to be wishy-washy because I think we're headed for, because of our sensitivity and testing now. I gave a talk recently to our grand rounds about the epidemic of overdiagnosis. I think we're overdiagnosing rheumatoid and inflammatory arthritis, and it's not your fault. I think it's us, the sensitive blood tests now we have, the patients going online and wondering if they have things. So I worry. I think it's way better for you to be wishy-washy than overdiagnose rheumatoid, because we rely, whatever's written on a radiology report, we rely on. So if you're being wishy-washy, it makes us rethink the diagnosis, which is better.
Great, thanks for that, and thanks for those questions. With that, I think we'll wrap it up. Thanks again, Kam, for a great talk, and I think as always the discussion and the chats are almost some of the most valuable part of the discussion and the lecture. So thank you for everyone who participated and for the questions. And we'll see you all hopefully next week for the next lecture.